good day to everyone. It's a pleasure to actually have you here for our global meet for the World Diabetic Day awareness sessions under DFO International. So we have a good program basically at this moment. We have already four groups which have already gone through, which is basically the Western Pacific region, and then the Southeast Asia region, Africa, and also MENA. Now we move towards the global meet. So we start off with a message from DFO itself. A very good day to all my friends and family members of our great DFO International. It gives me great pleasure to actually welcome all of you to our World Diabetic Day celebration with our healthy steps. DFO International, a mission with a vision. This is the new board members for 2025 to 2027. I would first like to thank all our regional chairs, regional advisors, country representatives, and full members for supporting us on the Healthy Steps Diabetic Food Awareness Day on the 16th of November 2025. DFO International is a registered international non-profit association under Belgian law, and the mission is to actually help people as a global organization consisting of people working in the field of diabetic-related food care. All are dedicated to providing food care. These people are spread across 7 regions in the world. Basically, Africa, SACA, MENA, NAC, Europe, Southeast Asia, and Western Pacific region. Our board members, regional chairs, advisory and our country representatives as full members are in all these 7 regions, according to the International Diabetic Federation and World Bank classifications. We would like to promote the global profile of diabetic food prevention and care through awareness, guidance, education, research, and professional development, ending avoidable lower limb amputations due to diabetes worldwide. We are actually the implementation arm of the IWGDF. Our goal is to prevent and reduce the number of unnecessary amputations from diabetes worldwide and improve the quality of their life. Training healthcare professionals how to manage diabetes-related food problems effectively and prevent amputations, giving healthcare professionals strategies to implement, develop, and sustain food services, and promoting the recognition of diabetic food specialists. So we want to close the gap of available and affordable diabetes food care. And World Diabetic Day is the culmination of our great work together. Our activities along the way includes training the food healthcare professionals step by step in each country, and our World Diabetic Day Awareness Week, which we're celebrating on the 16th of November. We have many partner organizations, if it includes the IDF, IWGDF, ISDF, Limb Preservation Alliance, the Royal College of Podiatry, the World Union of Woolly Societies, Diabetic Food UK, American Limb Preservation Society, the Canadian Podiatry Medical Association, Wounds Canada, International Associations of Diabetic Food Surgeons, DFSI of India, RK Diabetic Food and Podiatry Institute, Research Society for the Study of Diabetes in India, Interprofessional Wound Care Association, the International Committee of the Red Cross, International Université Numérique Francophone Mondiale. So we have many flagship programs, and the latest is actually Train the Food Trainer for healthcare professionals. And this is going to be carried out completely 2025, 2027, and we would like to kick off this basically in all the 7 regions. This is something that is a key performance indicator for all the regional chairs in all the 7 areas. This is our Diabetic Awareness Week. We start at 8 CET with the Western Pacific region and proceed to Southeast Asia, Africa, MENA. Global meet will be from 14 to 15:30 CET. And then we have got Europe, NACA, and SACA. We also have the webinar series, which is Sherlock Saturday, 14 CET for 2025-2027. We've already had the first session basically with Prof. Abbas from Africa, and then looking at hardest wounds and the surgical approach is the next one by Dr. Salma, and then I will cover on innovative wound care strategies, followed by different specialities from different areas, from podiatry, from plastic surgery, from nutrition, and also in terms of prevention. We have many newsletters which are ongoing continuously from 2023, 2024, 2025, 2026, 2027. And then we have got our leaflets, basically, which are completely being disseminated everywhere by all of you. Thank you very much. You're doing a great job. The cost of treating diabetic foot ulcers in 7 regions, basically, research is very important. We look at the Global Wound Care Journal, which I have the pleasure of being the editor-in-chief. And we actually came out with a journey from the step-by-step diabetic foot program to train the foot healthcare professionals, 22 years of preventing amputation globally. This is actually with Abbas and myself. And this is something as a great publication that we are very happy to put forth to you. At the same time, the Afro-Dial study, and then the Asia Afro-Dial study also, and our consensus document on the implementation strategies for the prevention and management of diabetes-related foot disease, which was updated, and we will actually update this in 2026 in Wounds National. And our 4th DFoot International Conference, which will be held in Maldives from the 1st to 3rd of May. Thank you very much to Dr. Wahid, the Vice President, who is Chairman of the organizing committee for this. So what we have done is every year, basically, we are having conferences in different parts of the world to actually support and also push for the advancement of diabetic foot management in terms of prevention and also to prevent avoidable amputation. I thank God for all of you as my friends and family in supporting me as president for DFoot International and the whole board as a whole, together with our sponsors, Ergo Medical, Monleka, and then even Oneness Bio for these great sessions. And we would like to thank you for continuously supporting us all this while. And in 2026, the World Union of Wound Societies, where we are actually a supporting society, will have the session from September 23rd to 27th of 2026 in Kuala Lumpur Convention Center with the theme of Global Paradigm Shift, Wound Management, Specialty and Recognition. I thank you for a great this session, and I hope that all of you all will be able to share your expertise and clinical know-how and try to actually help all our patients who are actually our clients. So with that, thank you again, adieu, and have a wonderful World Diabetic Day. And let's work together for the betterment of diabetic foot management, prevention, and to prevent amputation, and most of all, save lives, save limbs. This is truly important. Thank you again. God bless you all. I think with that, we proceed to the next part of this program. I think the most important part. I would first like to take this opportunity to thank our keynote speaker, Professor Francis L. Game, who is actually chair of the IWGDF and also consultant diabetologist at University Hospitals of Derby and Burton and the NHS Foundation Trust. He's also clinical director of R&D and the Derby Clinical Trial Support Unit and honorary professor at the University of Nottingham. It's a pleasure to actually have her here on a Sunday, basically, to be with us to present on diabetes-related foot disease, closing the circle around evidence, implementation, and benchmarking. Friend, you have the floor. Thank you.
Thank you. Let me just open my slides properly. Hopefully you can all see that. Thank you, Harry, for that kind introduction. Now, I think a version of this or different pages from the IDF Atlas of Diabetes have been shared throughout this meeting, but I'm not apologising for the fact that I'm going to show it again. And this is the prevalence and the predicted increase in diabetes around the world, and also showing where the burden of diabetes is falling and where the burden is likely to fall over the next decade or so. And you can see that there is a predicted 142% increase in the prevalence of diabetes in Africa, whereas in Europe, although there is an increase, it is only 10%. Nevertheless, this is an absolute epidemic which is causing a huge amount of distress and cost to many nations. But it's not having diabetes that's the problem. it's having diabetes and developing the complications of it that is the biggest problem, with cardiovascular disease, myocardial infarction, stroke, and heart failure in particular. And what we're interested in, which is the development of diabetic foot disease. And these data, again, come from the 2022 IDF Atlas, very carefully put together by my colleague, Matilde Moteira Soares from Portugal, and showing the prevalence of foot ulcers. Now, we don't know in many nations what the prevalence of foot ulcers is. We don't even know that in the UK of late, but and so the data are somewhat limited because we have very few national surveys. But nevertheless, some of these data for the prevalence are actually quite scary. Rather more reassuring, but probably not reassuring enough, was this paper from Pete Lazzarini and colleagues in Australia, where they put together global trends in diabetes-related foot disease. They took data up to about 2017 or so, but they again were looking at national data. So I don't think that these actually represent most of the nations of the world, because people don't publish unless they think it shows them in a good light. And so in theory, hospital admissions, minor amputations have gone down globally, but you only have to look at some of those lines to show that actually in some nations, and these are national data, and we don't know in many nations, minor amputations and major amputations have increased. And given the publicity globally that major amputations have had, and the St. Vincent Declaration, this is probably not good enough. And it's not just amputations. I think we're becoming increasingly aware that, sure, amputations are dreadful, and it's the one thing that the patients are scared of more than anything else. They're more afraid of having an amputation than dying. But the global disability of burden actually is increasing in terms of diabetic foot disease, but doesn't just relate to amputations with or without prostheses, shown in the pale green and the amber there. But actually neuropathy dominates, as does foot ulcers, in terms of global disability burden. And they're all on the rise. And you can see there the change in the burden in different countries, particularly again in North Africa and the Middle East. So we shouldn't forget that whilst we are trying to prevent amputations, we're trying to prevent many of the other diabetes-related foot diseases as well. That doesn't detract from the DFoot international mission, which is avoiding avoidable lower limb amputations worldwide, because this is what the patients are afraid of. But let's go back to the beginning. If we don't go back to the beginning, we're not really clear on what we can do about this. And this is a really important paper. It's a very old paper now. It was published by Roger Pecoraro in 1990. And for the first time, he showed that 80% of amputations in people with diabetes were preceded by a foot ulcer. And this is a statement which is widely made, and I've actually heard it made throughout the day, that means that 80% of amputations are preventable. It probably doesn't mean that 80% of amputations are preventable, but we know that if we can prevent an ulcer or get an ulcer to heal, we have an opportunity to reduce that amputation. And these are the data that underlie that. And you'll see that some people just went straight from ischemia to gangrene and had an amputation. And these data might not be relevant in the 21st century and with modern vascular interventions, but nevertheless, it shows the importance of ulceration and the development of ulceration in outcome. And I think it was particularly important because for the first time, the paper questioned prevailing dogma on the inevitability of diabetes foot-related complications. And when I was training, it was this, you're going to get diabetes, you're going to have an amputation. And I think this opportunity to prevent was a message that was missing, and sadly is still prevalent today. And so this allows us to build the stairway to amputation, and we denote it as a stairway because at every opportunity, whether that be treating people with diabetes so they don't develop the complications of diabetes, the surveillance and the preventative measures when they do get complications to prevent ulceration, or getting that ulceration healed to prevent amputation, means that we have an opportunity to step off or step down this stairway. And that's a really important message. This can be prevented. So let's think about what are the risk factors for the development of diabetic foot ulcers. And again, data from the same study, the Seattle Diabetes Foot Study, gave us some early signals of this. And this shows the things that we all know and are now absolutely imperative in diabetes foot screening, and that is checking for sensation using they used a 5-gram monofilament. Nowadays, we use a 10-gram monofilament. Previous history of foot ulceration, previous history of amputation, very high risk. The use of insulin in this study, which is interesting because it's obviously a proxy marker for something else, possibly duration of diabetes, but now we have much better agents to reduce cardiovascular disease. Good circulation prevents the development of ulcers, whether that be a TCPO2 or an ankle brachial pressure index, and vision, often forgotten, poor vision, retinopathy. If people can't self-care, then they can get foot ulcers. If they can't see their feet, they can't manage them. And orthostatic blood pressure drop is a proxy for autonomic neuropathy. So these are all the things that we already know and are now built into our annual foot screening, or should be. But what about that next step up on the ladder? What factors, if somebody presents with a foot ulcer, are associated with poor healing and not being alive and ulcer-free at 12 weeks? And these are data from the National Diabetes Foot Care Audit of England and Wales, which has now been running for over a decade and has now about 170,000 cases of foot ulcers. And in the green are the features of somebody, either the person or the limb or their diabetes, that means they are more likely to be healed in 12 weeks. And in the red, the factors that mean people are less likely to be healed in 12 weeks. And if you don't like looking at these graphs, we can present that pictorially so that the size of the blob on this image is the size of the variable, the contribution of the variable. So all of these things are associated with not being alive and ulcer-free at 12 weeks. And you can see that ischemia, certainly in the UK, dominates everything, having a large ulcer, having a deep ulcer, etc. You'll note that glycemic control isn't on here, and in the UK, it is not associated with a 12-week outcome. It is associated with the development of all of these complications, but it isn't associated with being healed at 12 weeks. Of most note is actually that the time to first expert assessment, so the delay in getting a person being seen by somebody who knows what they're doing, is actually the 4th biggest factor that denotes outcome in these patients. And that's really important because that's something we can change today. It is very difficult to change the prevalence of ischemia today. We're looking at reducing it in people maybe in 10 years' time with better diabetes care. But we can change today our systems that mean that people don't have to wait to get an expert opinion. Sadly, it's not done, but it is a very quick win in terms of outcome. And when we look at major amputations in 6 months, they're very similar. The area, ischemia, somebody continuing to smoke, a heel hindfoot ulcer, being older, being on renal replacement therapy is bumped up now, and Charcot. So these are things that if we have somebody with an ulcer, we want to prevent amputation, this is where we would put our resources in terms of reducing that outcome. So we know who's at risk. It's obviously much more difficult to actually do something about it to prevent amputation. We know what to do. What are we actually going to do about it? And here I'm going to move to talk about guidelines. And in particular, I'm going to talk about the IWGDF guidelines because we are partnered with DFOOT International. DFoot International is the implementation arm of the guidelines, and equally because I chair the editorial board, so obviously I'm not going to talk about anybody else's guidelines, that's obvious. I've left this slide up for a couple of seconds because that's the link to the freely available guidelines with all the data that's backed up behind these. If you want to go and have a look, they're extremely long, so I can't go into them. It is standard to produce a conflict of interest slide on the first slide. I've chosen to put it here because as far as the guidelines are concerned, it's particularly important for me to say that I have no personal conflict of interest, but I do have to declare that the guidelines were actually sponsored by the companies below. They didn't see guidelines in advance and they had no input into their development. But why do we need guidelines at all? You know, we can all go to the literature, we can all look at the evidence. Well, this is the most common guideline that I use in my everyday non-clinical life. And that is, I ask my guideline, my sat-nav in the car, my navigation system, to tell me the best way and how quick to get to London from my house in Nottingham. On this occasion, I've asked the question, how do I get there in the car? This is a guideline. This is not telling me that I have to go that way and I have choices. I might want to look at it in a bit more detail. I could ask a completely different question, and important because you'll answer. And this question is, how do I get there by train? I'm still going to the same place, but I actually want to use a different route. So the question is very important. Actually, I want to go in the car. But looking at this, I mean, we can look at it in a bit more detail. And when you look at a clinical guideline, it's important that you just don't read the summary. You look at the detail. What is this made up of? So I would want to know, looking at this, are the sources of the data trustworthy? Is the interpretation trustworthy? Well, I happen to know where the data comes from in my sat-nav, but you know, if it's only one person, then it's a bit difficult to say it's trustworthy. I need the information to be up to date because there's some traffic jams going into the outskirts of London, and maybe they'll clear or maybe they'll get worse. So I need it to be up to date to make my decision. I have some choices to make. I really don't like that motorway that goes around London here. I hate it. So if there's only going to be 2 minutes difference, I'll choose a different guideline. I'll choose a different route. I will be weighing up my choices. There may be sources of bias. Who is uploading the data? And do they have the same preferences as me to avoid the motorway? So that all of these things, and you use this and I use this every day, these are guidelines. They can be ignored and we need to know a little bit of information about them. So switching to clinical guidelines, there are some questions. Who are they aimed at? Are they aimed at, for example, in our route finder, are they aimed at people who are traveling by car, or are they aimed at people who are traveling by train? So who are these guidelines aimed at? Are they aimed at patients, healthcare professionals, tissue viability nurses, podiatrists? We need to know that when we're reading them. We need to know the sources of data. Are they relevant to my environment? Most importantly, are they up to date and is the interpretation valid? And it's really difficult now as we go into the era of rapidly expanding publication and online journals. And in 1997, we had very few papers to look at. This is just a quick PubMed search with the words diabetes and diabetic foot, and we've got over 1,700 publications in 2025. So it's really difficult to keep up to date with the literature. It's a big job. And somebody has to do it. But you need to know who's looking at the data for you and is the interpretation valid. So back to the guidelines. I can tell you that the IWGDF guidelines are updated every 4 years. Now, you might not think that that's quick enough, and sure, things change, but it's a really big job. It's probably more frequent than any other set of guidelines. The last guidelines were 2023. And we're in the middle of updating the 2027 ones now. This is a complex slide, but I am thinking back to our satellite navigation system in the car. The first thing we do is ask the question, where do we want to go? how do we want to get there? What actually is our outcome? Where do we want to be? And it's really important that we're very clear on the question. Otherwise, we'll get a completely different answer. And it's really, really important that we involve consumers and people with the disease and other experts in the development of these questions. Are these the right questions? Are these the right outcomes? Is this where we want to be? And so that's done at this stage. And then only then do we go to the literature, look at all the literature, make an assessment of the quality of the literature. Are we sure about the source of the data? Are we looking at things with bias? Are people putting data in and not telling us about the traffic jams? Maybe they've just, not included those. Are we getting positive data from things that are important to people but not necessarily to patients? What's the size of the effect? I say, if it's only going to knock 2 minutes off my journey, am I going to look at things, or am I going to look at an alternative? And then we do an overall assessment of the evidence. And then, and only then, do we start looking at guidelines. And that is balancing up, making those decision groups. Are we going to go with this? Are we do that? Is the balance of benefits or harms and values and preferences? All of these things that you almost do instantaneously in your head when you look at your car navigation system. But, we have to look at this very carefully as a group and look at the feasibility, the equity, the access, and actually the values and preferences of patients and stakeholders and carers. And only then and only then will we write a guideline. So it's a very prolonged process, which is why it really can't be done any more frequently than 4 years. At the moment, we have 7 working groups. We've got slightly more than 69 members this time, coming from 26 countries. In 2023, we asked 65 clinical questions. We've probably got more now, and looked at 75 different outcomes. We looked at 120,000 titles and overall looked at over 1,000 papers to assess the data. We also involved 119 experts from around the world from 63 countries, and the blanks on that map are where we haven't had in 2023 expert input to make sure we're asking the right question. To make it global and make it valid, the guidelines are translated into many different languages, but they're not just translated word for word. We work with local organisations, and many of you on the call have worked with us to make sure that they are relevant to the country and the healthcare system that are involved. It needs to be relevant locally. So that's the process. These are the guidelines. I'm just going to whiz through really quickly in terms of what they contain. If you haven't seen them, there is one on arterial disease. And this is a joint guideline between the European Society of Vascular Surgery and the Society of Vascular Surgery in the USA. So this is a truly global endeavour. And 2023 was the first time this was done. It's going to be done again in 2027. Really usefully, they produced an algorithm for what you should do to diagnose vascular disease. And there was also one for intervention, which I'm not going to show you. But what I am going to show you here is actually the number of best practice statements. You see there that anything in an orange box is a best practice statement. That means that they didn't have any evidence, any written evidence, trial evidence to go on. And this was essentially what we used to call expert opinion and is now called a best practice statement. So we would really hope that there is a little bit better evidence in these orange areas for us to be absolutely certain about what we're saying, because people can then deviate even further from these guidelines. They'll say, well, my opinion is as good as anybody else's. So that's vascular disease. Moving on, there was a prevention guideline, and they looked right across the board to identifying the at-risk foot, how frequently things should be inspected and examined depending on the risk level. Education, simple education for the patient, family and healthcare provider. This is a difficult one because it's not been validated in many different countries. But ensuring the routine wearing of appropriate footwear, also very difficult in a global guideline because availability is very different, and treating the risk factors for ulceration. So if you're interested in prevention, do go and look at that one. Guidelines on classification, I'm going to pull out a little bit more because this is an area where there is a lot of confusion. And I think this is an area where you have to really think, what is the question I'm asking before I decide on a classification system? We actually looked at 28 different classification systems, and only came out with scenarios for 3 or 4. But it is, no one classification will fulfill all of these requirements. So you really do have to think, well, what is the question I am asking before I look at which classification is important. So things like communicating, if I'm ringing up my local clinic, what features of the ulcer are they going to want to know in order for them to say, yes, get the patient here today, or actually this can wait until tomorrow. And so we decided that the Sinbad system initially, because everybody can use the Sinbad system, it has no complex equipment required. But if you have got the expertise and the equipment, maybe slightly more detail in the Wi-Fi system, particularly about arterial disease. But first line, you should at least use the Sinbad system. And this is why, because it is really, really simple. Clinical, using your fingers and your eyes throughout, you do not need any equipment. Whereas if you are in a centre of excellence, you want to talk to your vascular surgeons and you have the equipment, then maybe you could use a Wi-Fi to explain to them your concerns. In terms of actually predicting outcome, we didn't find any classifications that had the necessary validity for predicting outcome. And we think this is going to come from AI, because there are so many different features that predict outcome, and some of them are categorical variables, some of them are continuous. And we're looking to AI in the future to perhaps provide an algorithm that fits everything across the world. If the wound is infected, we suggest using the IDSA IWGDF system, and that's also in the infection guidelines. This has been used for many years now. That's the 2015 version we suggest you use. If you think somebody has PAD, then classify, use the Wi-Fi system. If you think if you have a vascular surgeon, there is no point in doing a Wi-Fi if you don't have a vascular surgeon or access to a vascular surgeon. But if you do, then they need a little bit more detail, and are the pulses present or not? And finally, for benchmarking and audit, and I'm going to come back to benchmarking and audit in a second, but we suggest using the Sinbad score because it's quick and easy, and it means that everybody across the world can do it, which means we can allow comparisons between people with diabetes and foot ulcers, between centres within one country, and even between countries. And just to reassure you, and also a plug for people that Abbas and I wrote together many, many years ago. This is how long we've been collaborating. And we actually validated this score in 3 different countries, 3 continents. So it is valid across the world. Then there is the infection guideline. Again, this is really difficult when different antibiotics and different flora are prevalent across the world. And despite this, they managed to come out with 25 recommendations, and Abbas was a member of this group. There is a very complex table that points you towards which organisms are usually present and which antibiotics, and it is complex, but it is possible to go through this table and look at your local flora, your local antibiotic resistances, and pick out a way of developing your local antibacterial guidelines. We've looked at PAD. I don't know why these slides have repeated. I do apologise. Then there's guidelines for offloading. Again, this was an algorithm which is really, really useful, starting with a person with neuropathy and a foot ulcer. Is it non-plantar? Is it on the heel? Is it plantar, forefoot and midfoot? And working down the algorithm in terms of best practice, which here for a forefoot plantar neuropathic also would be a non-removable below knee device. Previous iterations of this guideline have suggested total contact casting, and this is where our stakeholders around the world have really had an influence. We're aware of the fact that total contact casting isn't available the world over. And in some countries, it's really difficult to do because of the climate and the humidity. So a non-removable knee-high offloading device is recommended, and these can be off the shelf. But there are alternatives. And I think this is what's so lovely about this algorithm is this is the guideline, but there are alternatives if you don't have that, in the same way that there are alternatives to the routes that are shown on a satellite navigation system. Now, wound healing. We made 29 recommendations in the wound healing guideline, but the vast majority of them were negative, as in we suggest not or do not, because the evidence behind many of these wound healing interventions are very poor. We looked at 9 different categories of interventions, which are listed here. Throughout this guideline, we iterated very frequently that whatever the new intervention is, it should be compared with best standard of care, because we do know that with best standard of care, most ulcers do heal. It's just that they take a little bit longer in many cases. But if best standard of care hasn't been applied, then we will never know whether the intervention actually would work in addition to good standard of care. And actually, a lot of the studies we looked at were very poor. But we suggest that you don't routinely use enzymatic debridement, that sharp debridement should be done at the bedside, unless you work in an area of the world where sharp debridement isn't available, because perhaps you don't have the personnel, in which case you could use enzymatic debridement. We suggest using sucrose octasulfate when healing isn't progressing, and when best standard of care is already in place. We suggested using hyperbaric oxygen, again, where standard of care has failed and where the ulcer is ischemic or neuroischemic, and also, importantly, where resources already exist, because this isn't a cheap treatment. Again, topical oxygen as an adjunct where best standard of care had failed, and again, where resources exist, because it is not a cheap treatment. We suggest not using any growth factors or platelets or blood bank derived platelets, except the autologous leukocyte platelet and fibrin patch, which isn't available world over, but again, where standard of care has failed. Placental derived products, again, as an adjunct where standard of care has failed. This is, again, an expensive product. Negative pressure wound therapy in post-surgical diabetes-related foot wounds. This would be an interesting one for the group to look at, because there's a big UK non-industry government-funded trial which shows that actually there was no difference in post-surgical wounds. So that'd be an interesting one for the group to unpick in the future, but not in any other scenario for negative pressure. But throughout, we emphasize that these more expensive products should be used where standard of care alone has failed and where standard of care is already in place. And this is the basis of the practical guidelines in the IWGDF, and that is pressure offloading, ulcer protection, restoration of tissue perfusion, treatment of local infection, local ulcer care, and then and only then, if things aren't progressing, should you be using more expensive agents. Finally, how do we know we're doing a good job in our centres in order to prevent more amputations or get our ulcers to heal in the future? And this is where audit and benchmarking comes in. And the IWGDF suggested the SINBAD system as being quick and easy, no special equipment, and used in many places around the world. It's used in the National Diabetes Foot Care Audit of England and Wales. I'm just going to show you how this 6-point easy clinical system can be used very effectively to look at the outcome of ulcers in the NHS. So we've now got to say, this is 2023, but we've now got over 170,000 ulcers registered from most of the areas of the UK. And what we're particularly worried about is the ulcer registration rate, and we're working on that. So we don't think we're capturing all ulcers. But despite that, because of the numbers, we can see quite clearly FEA stands for First Expert Assessment. So that's time for the person to get to somebody who knows what they're doing with diabetic foot ulcers, preferably a multidisciplinary foot clinic, is associated with outcome. So the longer somebody sits and waits in a community setting or doesn't attend a clinic, the worse is their outcome. And this is quite clear, even if we're not capturing all. And the longer they are on the lens, we can look at longitudinally over as well, as I say, very nature, and can look at the country in terms of how people are performing. And we can talk to those centres where people are not performing well and not improving and see what we can do to support them. Now, because I work in England, we've got a very fancy dashboard. We can look at, we can click on various areas. We can look at measures such as big areas, the commissioners. We can look at time-based assessment. We can look at outcome. And we can just click through this, and we could look at Midlands, which is where I work, and we can break that down. But actually, you don't need a fancy dashboard. You can actually present the data as they are here. And this is people having major amputations within 6 months of first coming to the clinic. So this is people with ulcers, as a bit of a table in an Excel spreadsheet. So you don't need the fancy dashboard. You can pull off the data very easily, and you can see that certainly in NHS England, this is just England, and this is actually the latest data. It was only published a week ago. If you come to a multidisciplinary foot clinic with an ulcer in the UK, over 98% of you will not get an amputation. So back to our sat nav and where we want to be and questions to ask. What we're aiming at is actually avoiding amputations. And I think I've shown you how we can get there and not to be distracted by routes that somebody else has told us about that might not be of benefit. So you should be asking yourself, do you have the appropriate guidelines in your language and your healthcare systems to get us to this goal, and have we asked the right questions? Are the sources of the data in those guidelines valid? Are they trustworthy as the interpretation is correct? What are the sources of the bias? Who is providing the information? Do they have my preferences and the preferences of my healthcare system and the patients at heart? And most importantly, is the information that I'm looking at up to date? And can I assure myself with benchmarking that I'm actually on the right road by looking up from time to time, having a look at my progress and seeing where I am? And so with that, I'll draw to a close and happy to take questions. Thank you very much for your attention.
Thanks, Tren. Wonderful talk. I think we'll keep it to the end. We just go through one short session with Emilio Galia, who's actually a nurse consultant from Malta, but now has moved to what do you call that, France. He's actually the Global Medical Education Manager for Ergo. So he will give a short presentation, and then we'll finish off with a final quick Q&A. Emilio, you have the floor. Thank you.
Thank you very much, Prof. Harry, for your kind invitation for this session today. And thanks, Prof. Screen, for such an eye-opener of a session. You talked a lot about evidence-based practice, why we do need guidelines, and evidence-based practice will definitely make sure that we are giving that quality care that our patients do deserve to get the best outcomes for them, but also to improve cost efficiency. Our focus today will be a little bit on debridement, and the traditional methods of debridement usually will have a few limitations. Either we cannot provide them, or we don't have the equipment, or we don't have the knowledge how to do it. So one thing that can support clinicians today is the polyabsorbent fibers, which are considered as something that can be done by all practitioners in their home base. The polyabsorbent fibers were recently in the Diabetic et al. The Brightman guidelines to show that the efficacy is through these electrostatic charges that they produce. They come either with silver, with the ergoclean, or with this cross-octosulfate or nanosaccharide factor, which is recommended by the IWGDF. Other dressings like seed dressings, they do have this. However, what was the polyabsorbent fibers are closer together, and there probably is a better debridement action on their part. Having in vitro studies are great, but having obviously outcomes on patients is better. And this is from a study that was conducted fibers provided better outcome than from this thing. So the first solution, if we have a wound which is infected, is the magnet fibers with the silver, which is the ergoclean AG, where there is a lot of clinical evidence, as you can see, and evidence-based practice is definitely at our heart. The dressing that probably is of more interest for diabetes-related ulcers is the Urgostart Plus treatment range, or the TLC and OSF, or as they are mentioned in the IWGDF guidelines, is the sucrose octosulfate, has a lot of evidence behind them, and they are in the guidelines because they have a double-blind study, which is the Explorer study that was conducted a few years back, but also real-life studies that confirm how much time is saved. And because time is saved, we have the cost-benefit analysis from 7 different countries, which do recommend. So the Urgostar treatment range, the sucrose octosulfate dressings, are in the IWGDF guidelines. They are also recommended by the NICE in the UK, and they are also in the guidelines in Vietnam for the Ministry of Health that actually suggests to use both the TLC with the AG, that is the ErgoClean AG, and the Urgostart Plus treatment range. This is a very easy algorithm of how to start off if you have an infected wound with the TLC AG, the ErgoClean AG, and then the sequential treatment with the TLC and OSF or the Urgostart Plus treatment family. There are also publications which showcase the sequential treatment of these cases. This is not just in the guidelines. This is, for example, a case series that was published from the Middle East, where very interestingly, there's quite a few comments by the clinicians themselves where they suggest that the use of the sequential treatment of these 2 dressings give a very positive outcome. Another one from APAC, where clinicians from India tried, as you see in diabetic foot cases, where they started off with the ErgoClean AG, they resolve the infectious status, and then they move on to the Urgostart Plus treatment range to shorten that healing time. It's not in diabetic foot ulcers only. This was an interesting paper that was published a few months back from Poland, where these were cases during the COVID period. And actually, one of the patients with the pressure ulcer that you see in the middle was changing the dressings himself. He was a paraplegic patient, and because of COVID, nobody could visit his home. And therefore, the science is there for us, but it's easy to use and practical to use and available for all clinicians. Thank you very much again for your very kind invite. And if you have questions, please let us know. Thank you.
Thank you very much, Emilio. I think we open up for questions from the panel. For Fran and also Emilio, sorry. Daniel, yep, just have to unmute yourself.
Congratulations to Fran's game. We have to the importance of the term time is tissue, and we have to learn to the importance of to learn to the physicians of primary care. This is the most important.
Yeah, I absolutely agree with you, Daniel. I mean, sometimes I feel that I'm preaching to the already converted, because we all know how important it is to get patients to us quickly, but it is about that influencing outside the hospital. But that's where, when we've got, and we're very, and I know how fortunate I am working in a national health service, is that actually we can work with the people that are supposed to be commissioning and paying for services to say, well, you're paying more, because unless we get patients in quickly, it's going to cost more to heal them because they're going to be more severe. So work with us to work with our primary care colleagues to provide education, and that will pay for itself in terms of the money that you're spending on trying to get people healed. And because we do have a national health service and general practice is part of that, we are able to influence it. But it's a constant process as people move on and practice nurses change. It never goes away.
Yes, because if we saw and we read the fast track, is very important, and we are applying in region SACA. This important because in Eurodial is very terrible what happened with primary care.
Yeah.
Okay.
And Fran, how do you think in the terms of using AI basically now? I mean, in terms of prescriptive analysis, where are we with that? I mean, do you think by 2027 we're able to come up with at least an app which can, with all the recommendations basically put in, like what we had last time with the Wound Metrics group in the US for the CDC guidelines?
So we did a systematic review of AI systems. It wasn't actually published with the last guidelines, but it has actually very recently been published. And at the moment, the AI is not suitable for prediction either, or the AI systems that have been actually published. And people get very confused between association and prediction. And a lot of systems will be associated with, but not predicted. So at the moment, we haven't found up until our most recent review, but it's something we'll look at again. But it's the obvious, isn't it? It's the obvious way forward because of the complexity of the disease that we're dealing with.
Well, I think I agree with you fully, because one of the things is getting to the people everywhere. And it seems nowadays TikTok and everything seems to go to more places until even presidents are actually buying up stocks in TikTok and all that, if you know what I mean. So it's, the movement is in that kind of a sense.
Exactly.
The other thing is, I think you also mentioned that, in terms of therapeutic products per se and all that, there's not many which has actually come through. So I want to ask Emilio, your ErgoClean AG or your hydrodissolving fiber with silver, I think you have done what you call this, some randomized trial basically on that. Is there, the published papers, are they available basically for the IWGDF wound healing site to review? Currently.
Yeah. The study that I showed, the sloughing that was published on the Journal of Wound Care. However, it was only a small randomized control trial. It wasn't that big. Obviously, we have the sucrose octosulfate because the Explorer study was double-blind, it was top of the range. The combination is different. You have the fibers with the silver and the fibers with the sucrose octosulfate. I think, honestly speaking, with diabetic foot ulcers, the sucrose octosulfate, as suggested also by the NIC, is very much there, available for everybody.
I think one of the things that I was talking about, I mean, I'm looking at is basically like what Fran was mentioning, that enzymatic debridement is actually not suggested. You should do more bedside, and that's what most of us do. But in additional with your Ergreen AG in terms of basically as for desloughing and all that, I mean, if you have sufficient studies during this period, it's good, at least what they call it, review. But however, I have to warn you, basically, it is all level 1 evidence. And what do you call that with the gate methodology. I'm also one of the reviewers, so that's why I'm it's we don't want to actually put anything inside there with a lower grade or lower levels of evidence.
Well, basically, there's a consensus guidelines from the APAC region that one of the main author is in our presence today. So yeah, the efficiency of the product is there, but I don't think that there is high level randomized control trials that could put it in a guideline.
Okay, so that's a good idea to start. Actually get that. I think because whenever we discuss, even in the board and everything else, we always come to one aspect only. Basically, most people do basic research and then start selling. They don't go inside that. For Ergo Start, basically, it's been in for quite a number of years. So we're quite happy with it. But with the newer ones, I think it'll be good if you actually indulge us in doing something more evidence-based at level 1. So it'll be easier for us to actually, review those evidence.
I'll send a message to Dr. Serge Bobo.
He knows. I've discussed it with him many times.
Okay, anything else from the group? If not, from the participants, any other questions? Abbas, anything? Salma, Wilma, Wahid, Simone?
Wonderful chats.
Thanks. Fran is always wonderful, so no problem.
Well, I can only say Fran was wonderful as always. No doubt.
All one evidence.
Yes. But really, I feel the message which should go through is the message of late referral. And we should all really work hard on forcing this philosophy to the primary care level, that they get the message, and also to our patients who attend our clinics, that they get the message and don't wait at home. Because I see still too many people coming too late when their toes or feet or legs are condemned to death. So it's us, we can make a change.
I think that's the main thing. I think that's why we want to actually have more of train the foot healthcare professionals, all that, shorter periods, quick ones, all over the regions. And I've also, when I actually address all the chairs and the advisories, committees and all that, I told them there's their key performance indicator. That means every year they have to do one, whether they like it or not. So I think Daniel and his team in Saka also have done it in Colombia and all that. So even we have done it in Malaysia, Abbas has done it. So, and you have done it also. So we need to actually basically get more people involved. I think more countries should be doing it, especially now since we have quite a number of countries in our fold. So we hope to actually get a communique out to them to actually see what are the ones and how we can help them basically. Because I mean, with the info cards, with the fast track pathways and all these things, all these have to be strengthened again. Because I mean, we show them in our lectures and all that. But interestingly, you find nowadays after COVID, everybody wants to have physical meetings and all that. They are not so enticed or seduced by having webinars per se. So in that sense, we need to find whether we can actually, I mean, it's in different languages, but see whether how to disseminate to all the chairs. So
Maybe
second set off.
Sorry, if I may have just one more remark, it's not only raising awareness among the patients and healthcare workers, but also among the profiles who are not healthcare workers, but do the foot care. It's, for instance, the pedicurists. And it's something which will be discussed later on in our session, how to integrate all these profiles into the foot care system, and also to increase their level of knowledge and to classify their competencies.
Couldn't agree more. That's why they start doing caregiver modules and all these things. And you'd be surprised that in most countries, because of the geriatric age group now, a lot of caregivers are actually being brought in from different parts of the world. And most of them don't come in with proper competencies and all that. So they need to have this to actually recognize it. I think the most important is recognizing these red signs and all that, and actually planning ahead and speedy referral. Because if you don't tell the children and all that, it's going to get a problem. Even though we have got wonderful EMRs and PAD devices and all these things, but if it's not informed to the family or whoever's going to take charge of the whole thing, I mean, from the caregiver point of view, it's going to be quite difficult also. Okay, Salma?
I have a point to mention. There are 2 points regarding Orgo. I will not talk about Orgo, otherwise you would say I'm biased to it, but it is one of the best products been used for the patient with very good results. The second point regarding what Wilma was mentioning, that we need to detect early and refer early. And I believe it's not only by early examination for diabetic patient, also we need to screen all the patients, because some of the patients may be underdiagnosed, not as diabetics, but they are diabetics, but they are not diagnosed. So screening all the patients who present to the primary healthcare, examine their feet to detect as early as possible, even before diabetes started or diagnosed. This is what I believe.
True. I think what you call it, all aspects, because the thing is, we always talk about the patient, caregiver, family, and all these people, I think, but I think everybody should be involved. So it could be companies, it could be industry, it could be anybody, basically. Daniel, you have your hand up?
Yes, 2 questions. In SACA, we will join nurses and podologists to teach them. Is a good idea?
Yep, I think, Fran, what do you think?
Sorry, I
Thank-
didn't catch the question. Can you repeat it?
Yes, in region SACA, we will join to learn them nurses and podologists, because they are good. And another thing that we have to examine neuropathy in pre-diabetes.
Yeah. So yes, and I think learning as a multidisciplinary team is really helpful. And from my point of view, your job title shouldn't stop you having the skills, as long as you have the training and the competency and your healthcare professional body agree with it. So we're a little bit stuck sometimes in the UK about what the healthcare professional bodies say. But from my point of view, it shouldn't matter what your name is, as long as you have the skills and the training and the competency to do so. And, all learning together as a multidisciplinary team is really important. I think you'd have to look really hard at the cost effectiveness of screening for foot disease in pre-diabetes, because actually the incidence of disease is very low. And certainly in the UK, it's been looked at, and we're looking to find those people with pre-diabetes, because then we have a program to reverse their prevention of developing diabetes. But foot screening isn't actually in there at the moment, until we examine the cost effectiveness of doing so. And there's also a psychological burden on the patient that we have to remember.
Yes. In pre-diabetes is very low the incidence of neuropathy.
Yeah, exactly. And so we would have to think very carefully about the cost effectiveness of doing that, or rather, do we put our resources into a program that actually reverses their development of diabetes? And we have that program in the UK to reverse to bring them back and prevent diabetes.
Thank you very much. Thank you very much.
Harry, I just add to this podiatrist thing. We up till now don't have a podiatrist, and it's not even accepted by Ministry of Health in Sub-Saharan Africa. So we do teach our nurses, and they are actually better than even podiatrists. They are mini surgeons. So they do that much work, and Ministry is happy with that. So we just carry on. Let's see where we reach. And I've been teaching them.
Get on.
I've been teaching them since 2003 now. So the work is, and we have a heavy load, and they are the backbone of doctors as well. Yeah, Eric.
Yeah, I think in Pacific region, same thing also. We only have podiatrists in Singapore and also in Australia and all that. The rest of the countries don't have it. So basically, our nurses are actually nurses come podiatrists because they do all the offloadings, they do all the bedside debridements and all that. So it helps a lot. And I think it's not taught in the nursing schools and all that, but with a bit of post-basic training, plus also training of the nurses on sites and all these things, they have actually started to do that. They do it slowly, but I think in Malaysia, we are a bit lucky in the sense that there is no legislation against a nurse doing bedside debridement, because in some countries such as the Philippines and also in, I think, South Africa, you cannot allow any amount of blood to be actually seen in the wound itself. So they can't touch any scalpels or anything. That becomes a bit of a problem. Daniel, you're saying?
Yes, they are not podiatrists. They are not physicians. They are podólogos. They are not doctors. They are like Lázaro. They are not physicians. Podiatras,
the nurses.
Podiatrics are physicians. They go to surgeries. They are podólogos. They are different,
Actually, what surgeons you are taking that are common in North America only. But in others, they are not surgeons. The podiatrists are not surgeons. And they are not even physicians. It's a different field of 3 years.
Okay.
And there is Wilma, if you remember, we did prepare a course on podiatrists under International Working Group. And you did the first, and then I also did it in Tanzania, and same thing was done in Pakistan. Helping the nurses come. But there was a lot of outcry that we are going to give a wrong impression, and then it didn't went the way it's supposed to go. Anyhow, but we are still carrying on doing it.
Okay, thank you.
Okay, I think it is.
Okay. Thank you, friend.
This one, Simone has given a question, for Emilio. I think that one you have to pass it to your sales side. One quick question: does Ergo have a representative in the Caribbean?
No, we don't, but I can always suggest to my boss to send me a couple of weeks to Barbados. I don't mind.
Superb holiday. We cannot also forget the importance of standards of care being disseminated via our health ministries. Once health ministries have bought into the process, this will make a big difference. Yeah, from Simone. I think that is basically from legislation and also from the government side, which I think is quite important. Like in Malaysia, that's what we did. We went straight to the minister's side. So we have a secretariat basically in the ministry itself. So the budgets are coming from them. And then we have already set up the teams in about 150 hospitals and 890 health clinics. So top-down approach, very fast, one order straight out, 2011, 2017, 2 different letters, and everybody has gone advanced wound care. And then last year, we started the approved product list. That's basically the itself with the Ministry of Finance starts purchasing basic wound dressings and all that, which you can actually use with no local purchase orders or without actually no CAPEX for you. and the department level. That means for us doctors, basically, we don't have to use our departmental budget for any of those things. Okay, is there anything else? All right. I think if there's no other questions, we had a very good session. Fran, as usual, thank you very much. You have been utterly wonderful. Hope you have a wonderful time over this week.
Thank you. Thank you, everyone.
Emilio,
Congratulations.
same thing. You're lucky that we invited you, so at least you have a chance to go to Barbados. But don't forget the study,
Once he
level 1
brings a
and level 7.
suitcase full of dressings, that's fine.
Yeah.
Okay, you need to pack up at least 2 kilos or 3 kilos of dressings. That means. Okay, I think thank you very much, and we will move later on to the European meet.
So-
Vilma, you can start.
Yeah, okay. So, good afternoon, ladies and gentlemen. It's my pleasure to be your host at the Healthy Steps Awareness Day Europe. Welcome and good afternoon from very cloudy Ljubljana. The reason why we organized this kind of session is that foot problems, gangrene, and amputations remain a serious and much feared complication of diabetes. In spite of excellent evidence-based guidelines, we have heard about them today. The situation in Europe, in particular in Eastern Europe, is still far from perfect. And implementation of the knowledge and skills remains a challenge. Licensed podiatry education is still unavailable in many Eastern European countries. So we wanted to address this problem, and the aim of our session was to show some good initiatives which might in the future pave the path towards better foot outcomes. But first of all, a welcome message from our president.
Thank you, Vilma. Can I make a play? A very good day to all my friends and family members of our great DFU International. It gives me great pleasure to actually welcome all of you to our World Diabetic Day celebration with our Healthy Steps. DFU International, a mission with a vision. This is the new board members for 2025 to 2027. I would first like to thank all our regional chairs, regional advisors, country representatives, and full members for supporting us on the Healthy Steps Diabetic Food Awareness Day on the 16th of November 2025. DFU International is a registered international non-profit association under Belgian law, and the mission is to actually help people as a global organization consisting of people working in the field of diabetic-related food care. All are dedicated to providing food care. These people are spread across 7 regions in the world. Basically, Africa, SACA, MENA, NAC, Europe, Southeast Asia, and Western Pacific region. Our board members, regional chairs, advisory and our country representatives as full members are in all these 7 regions, according to the International Diabetic Federation and World Bank classifications. We would like to promote the global profile of diabetic food prevention and care through awareness, guidance, education, research, and professional development, ending avoidable low-early amputations due to diabetes worldwide. We are actually the implementation arm of the IWGDF. Our goal is to prevent and reduce the number of unnecessary amputations from diabetes worldwide and improve the quality of their life. Training healthcare professionals how to manage diabetes-related food problems effectively and prevent amputations, giving healthcare professionals strategies to implement, develop, and sustain food services, and promoting the recognition of diabetic food specialists. So we want to close the gap of available and affordable diabetes food care. And World Diabetic Day is the culmination of our great work together. Our activities along the way includes train the foot healthcare professionals step by step in each country, and our World Diabetic Day Awareness Week, which we're celebrating on the 16th of November. We have many partner organizations, which includes the IDF, IWGDF, ISDF, Limb Preservation Alliance, the Royal College of Podiatry, the World Union of Woolly Societies, Diabetic Foot UK, American Limb Preservation Society, the Canadian Podiatry Medical Association, Wounds Canada, International Associations of Diabetic Foot Surgeons, DFSI of India, RK Diabetic Foot and Podiatry Institute, Research Society for the Study of Diabetes in India, Interprofessional Wound Care Association, the International Committee of the Red Cross, International Université Numérique Francophone Mondiale. So we have many flagship programs, and the latest is actually Train the Foot Trainer for healthcare professionals. And this is going to be carried out completely 2025-2027, and we would like to kick off this basically in all the 7 regions. This is something that is a key performance indicator for all the regional chairs in all the 7 areas. This is our Diabetic Awareness Week. We start at 8 CET with the Western Pacific region and proceed to Southeast Asia, Africa, MENA. Global meet will be from 14 to 15:30 CET. And then we have got Europe, NACA and SACA. We also have the webinar series, which is Sherlock Saturday, 14 CET from 2025-2027. We've already had the first session basically with Prof. Abbas from Africa, and then looking at hardest wounds and the surgical approach is the next one by Dr. Salma, and then I will cover on innovative wound care strategies, followed by different specialities from different areas, from podiatry, from plastic surgery, from nutrition, and also in terms of prevention. We have many newsletters which are ongoing continuously from 2023, 2024, 2025, 2026, 2027. And then we have got our leaflets basically, which are completely being disseminated everywhere by all of you. Thank you very much. You're doing a great job. The cost of treating diabetic foot ulcers in 7 regions, basically research is very important. We look at the Global Wound Care Journal, which I have the pleasure of being the editor-in-chief, and we actually came out with a journey from the step-by-step diabetic foot program to train the foot healthcare professionals, 22 years of preventing amputation globally. This is actually with Abbas and myself, and this is something as a great publication that we are very happy to put forth to you. At the same time, the Afro-Dial study, and then the Asia Afro-Dial study also, and our consensus document on the implementation strategies for the prevention and management of diabetes-related foot disease, which was updated, and we will actually update this in 2026 in Wounds National. And our 4th DFOO International Conference, which will be held in Maldives from the 1st to 3rd of May. Thank you very much to Dr. Wahid, the Vice President, who is Chairman of the Organizing Committee for this. So what we have done is every year, basically, we are having conferences in different parts of the world to actually support and also push for the advancement of diabetic foot management in terms of prevention and also to prevent avoidable amputation. I thank God for all of you as my friends and family in supporting me as president for DFOO International and the whole board as a whole, together with our sponsors, Ergo Medical, Monleka, and then even Oneness Bio for these great sessions. And we would like to thank you for continuously supporting us all this while. And in 2026, the World Union of Woolly Societies, where we are actually a supporting society, will have the session from September 23rd to 27th of 2026 in Kuala Lumpur Convention Center with the theme of Global Paradigm Shift, Wound Management, Specialty and Recognition. I thank you for a great this session, and I hope that all of you all will be able to share your expertise and clinical know-how and try to actually help all our patients who are actually our clients. So with that, thank you again. Adieu, and have a wonderful World Diabetic Day, and let's work together for the betterment of diabetic foot management, prevention, and to prevent amputation, and most of all, save lives, save limbs. This is truly important. Thank you again. God bless you all.
Okay, thank you very much for the kind introduction. Now it's time to move to the 4 presentations which we have prepared for today. And I would now like to introduce the first one. The first was prepared by Jerneja, Uhan and Janko, Žmitek. They will talk about podiatry education and competences. In fact, they will present the Slovenian approach, but let me introduce the 2 speakers. Jerneja Uhan. She obtained a master's degree of musculoskeletal science, surgery, and interventional science at University College of London, and in the year 2023, a PhD degree in musculoskeletal science at University of Oxford, where she still works. But the inspiring thing about her, we can read on her LinkedIn profile, that she is now looking forward towards seizing the opportunity to channel her skills and problem-solving abilities to career in which they can flourish. And one of the places to which she feels very much connected is the Faculty of Applied Sciences in Ljubljana. And the Dean, Professor Janko Žmitek, who was indeed the driving force in the process of installing the podology study in Ljubljana, and he's also an enthusiastic, hard-working member of the working group that has put together the document on regulation of the pedicure profession in Slovenia. So let's listen to what they have prepared.
There is always a reason behind change. In Slovenia, this initiative was driven by 2 very serious ones. First, in 2015, our country ranked first in the European Union for lower limb amputations. While we often take pride in being at the top of various lists, this is certainly not one we wish to remain on for long. The second reason came from the field itself. Pedicurists recognized that everyone was doing everything. There was significant overlap in practice, with no clear professional boundaries or standards, particularly when it came to the so-called medical pedicure. These 2 factors together provided a strong rationale for establishing the Working Group for Pedicure Regulation, supported by the Ministry of Health and the National Coordination Group for Diabetes Management. The goal is to standardize care, ensure that service providers work within defined competences, and ultimately improve patient safety by recognizing that inadequate foot care directly contributes to diabetes complications and poor health outcomes. First, we began with a simple research survey among practitioners to understand their education levels and the type of services they provide. From the 184 responses we received, it quickly became clear that regardless of education, most practitioners were performing all types of pedicures, including those for diabetic patients. This confirmed that the field was completely unregulated. Education levels varied widely, from short non-formal courses to university degrees, yet there were no clear standards defining who could perform specific procedures. This lack of structure created inconsistencies in practice and increased risk for patients. To address this, a national working group was established, bringing together academic institutions, clinical experts, and representatives of the profession. Our goal was to create a clear structure that defined different types of pedicure, the related competences, and a transparent system for recognizing qualified practitioners. I would also like to emphasize that the group was open to all practitioners, regardless of their level of formal or non-formal education. The goals are both professional and public health orientated. We aim to standardize education and practice, protect clients, and strengthen the connection between wellness and healthcare systems, ultimately improving patient outcomes and reducing avoidable complications. It may sound straightforward, but the process was far from linear. Despite having a clear vision, each stage required review, revision, and collaboration to ensure the proposal was accepted and aligned with all stakeholders. For the first time, the type of pedicure have been formally classified based on the client's health condition and the complexity of care required. This classification defines clear boundaries between aesthetics, preventative, and medical level procedures. It ensures that each practitioner operates within the scope of competence according to their education and training. The system also introduces a structured framework that links the level of qualification with the type of client they can safely treat. In practice, this means that clients with complex health conditions such as diabetes or circulatory disorders are only treated by professionals with the appropriate medical knowledge and skills. This not only raises the standard of care, but also protects both the practitioner and the patient. The creation of the education and competence levels within this framework is one of the key intermediate outcomes of the project, developed specifically as a response to the needs identified during the analysis phase. Competence in this framework is directly tied to formal education. Each level of qualification defines the scope of practice a practitioner is trained and authorized to perform, creating a clear and transparent professional pathway. Higher levels not only build on the skills of the previous ones, but also include broader clinical understanding, patient safety knowledge, and interdisciplinary collaboration. This approach encourages lifelong learning and professional growth, allowing practitioners to advance through additional education and specialization. Importantly, in 2024, Slovenia celebrated the graduation of its first cohort of university-level podologists, a milestone that marks the beginning of formal academic recognition for this field and set a strong foundation for integrating podology into the wider healthcare system. Competences in this framework are defined both theoretically and practically, ensuring that the practitioners not only understand the principles of safe and effective food care, but can also demonstrate them in a real-world setting. Each educational component is aligned with the European credit transfer and accumulation system, allowing for transparency, comparability, and recognition of qualifications across Europe. The alignment guarantees that training programs meet international academic and professional standards while supporting mobility and further education within the European Union. To maintain these standards, practitioners will be subject to regular reassessment and skills validation. To ensure continuous professional growth, the system is designed to promote lifelong learning. We are taking inspiration from successful international models where practitioners are supported through structured education pathways and professional oversight. A key part of this framework is the introduction of a regular competency assessments overseen by the Ministry of Health to maintain consistent standards of care and patient safety. In addition, a new profession chamber will be established to act as a regulatory and support body, much like the existing medical and nursing chambers. This chamber will guide practitioners, uphold ethical and professional standards, and provide opportunities for ongoing education and development, ensuring that knowledge and practice evolve hand in hand. Implementation will be gradual to ensure fairness. Practitioners will have time to align their education and practice with the new framework. A central registry will make it clear who is authorized to perform which type of pedicure. Ultimately, this reform aims to protect clients and elevate the profession. With standardized training, clearer roles, and defined competences, we expect significant improvements in both patient safety and professional credibility. This initiative marks a true turning point for Slovenia. It formally recognizes the importance of preventative food care, the value of professional standards, and the essential role that pedicurists and podologists play in protecting public health. And most importantly, well, finger crossed, we hope that Slovenia will soon hand over the unwanted first-place position for lower limb amputations. Do we have any volunteers? We are happy to hand the baton. Thank you.
Thank you, Jerneja, for the very clear, systematic presentation. We shall have the discussion at the end of the whole session. So now I would like to introduce the second talk, which will be presented by Ljubiša Pađen and Zdenka Tičar. And the good thing is that this is the presentation which is indeed from Slovenian Ministry of Health, which is good news, because that means that the policy makers, the decision makers are interested in improving the food care level in Slovenia. Ljubiša Pađen finished his studies in nursing in Slovenia, but then obtained his PhD degree at School of Nursing in Manchester. He was a senior lecturer in nursing department at Faculty of Health Sciences in Ljubljana, but since February 2024, he's a senior lecturer in adult nursing at University of Manchester. He's still tightly connected to Slovenian Ministry of Health, where he's been partly appointed for almost 5 years. Dr. Zdenka Tičar is from Slovenian Ministry of Health, and she is the leader of the working group for developing the national strategy in wound care. But besides, she really has great experience in nursing, because her professional pathway was from a nurse in the intensive care unit, then to district nurse, but then she graduated at the Faculty of Public Administration and then obtained her master degree at Faculty of Government, and in 2018 she obtained her PhD degree at Faculty of Public Administration. So let's listen to what they have prepared.
In this presentation, my colleague Ljubiša Pađen and I, Zdenka Tičar, will briefly introduce the National Strategy and Action Plan for the development of healthcare management of patients with wounds, incontinence, and ostomies, adopted by the government of Slovenia. We will look at why the strategy was developed, how it's being implemented, and focus in particular one of the key objectives of the action plan, namely the review of education. The strategy was developed in response to demographic and epidemiological changes, an aging population, increasing chronic diseases, and more patients living with complex wounds or stomas. We also observe differences in access to specialized care and variability in the competencies of healthcare professionals. The aim of strategy is to improve population health and reduce the burden associated with wounds, ostomies, and incontinence. It seeks to ensure the integrated and coordinated care at all levels of the healthcare system, bringing services as close to the patient's home as possible. The strategy outlines 7 strategic objectives that form the foundation for a coordinated, evidence-based system of care. These include the development of clinical pathways and guidelines ensuring equally trained healthcare professionals and improving infrastructure and reduces. A special focus is placed on digital transformation, introducing telemedicine and electronic patient records and the national data feed. Finally, the strategy highlights the importance of awareness, research, and the establishment of regional and territorial reference centers to ensure high-quality, equitable care across Slovenia. Research and establishment of regional and territorial reference centers to ensure high quality, equitable care nationwide. The strategy is in implementation is guided by a 2-year action plan overseen by an interdisciplinary working group within the Ministry of Health. This group ensures coordination across institutions and sectors. Its main tasks include reviewing and harmonizing educational programs, preparing proposals for the transfer of professional competencies, and developing a unified digital infrastructure through an e-record and national registry. In parallel, the group supports the creation and continuous updating of clinical guidelines and pathways to promote evidence-based practice and ensure constant high-quality care through the healthcare system.
Thank you, Zdenka. I will now continue by highlighting one of the key objectives from the national strategy, the review of education and competencies of healthcare professionals. The purpose of this objective is to systematically evaluate and standardize the competencies that healthcare professionals acquire through pre-university, undergraduate, and postgraduate education, as well as through informal training. The review focuses on all 3 areas, so wound care, ostomy care, and incontinence. The ultimate goal is to ensure a structured and consistent development of knowledge and skills across all healthcare professions, so that we can continue to build a strong, capable, and confident healthcare workforce for the future. We started by analyzing the integration of wound care education across all levels of healthcare training, from secondary level nursing education to higher education for all health professionals, including nursing, medicine, physiotherapy, occupational therapy, and orthotics and prosthetics, as well as postgraduate programs. Data were collected from secondary schools, universities, colleges, and non-formal education providers offering specialized or continuing professional training. To ensure comparability, the UMA framework was applied as reference standard as it defines the core learning outcomes and competencies relevant for wound care and management. This approach enabled us to assess how well Slovenian educational programs align with international standards and also to identify areas where learning outcomes are only partially achieved or still missing. This heat map shows how well individual educational programs achieve the expected wound care competencies based on the UMA framework. As you can see, medicine and nursing programs show very strong alignment. In fact, medicine aligns fully with the expected learning outcomes, and nursing programs delivered in higher education and guided by EU directives also show high alignment across almost all competencies. Other health professions show more variability, which is expected. For example, midwifery focus mainly on acute and surgical wounds, while orthotics and prosthetics emphasize wound prevention through pressure management and load distribution. These variations highlight the need to better integrate shared wound care skills and knowledge across all health professions, ensuring that everyone involved in patient care works from the same foundation. The results serve as strategic foundation for implementing the remaining components of national strategy. By identifying where competencies are well aligned and developed and where gaps persist, we can now develop a competency framework and recommendations that define clear standards for all healthcare professions education involved in wound, ostomy, and incontinence care. These findings will also guide curriculum updates, promote consistent clinical training, and inform the development of national guidelines and clinical pathways. Ultimately, this process also strengthens the connection between education, evidence-based practice, and overall healthcare system performance, ensuring that every patient receives safe and high-quality care regardless of where they are treated. The national strategy represents a major step towards building a unified patient-centered system of care. By aligning education, clinical practice, and policy, Slovenia is laying the foundation for consistent evidence-based standards across all healthcare professions. The competency analysis has provided clear insight into strengths and gaps in training, helping to guide curriculum updates and professional development. Through collaboration, digital transformation, and standardization, we are creating a system that ensures every patient, regardless of where they live, receives safe, equitable, and high-quality care. Thank you for your attention. If you would like to learn more about the project, share insight, or explore opportunities for collaboration, please feel free to reach out using the email on this slide.
Okay, thank you both. We have now seen the two parts of the puzzle of the organizational aspect of food care. And now I'm happy to talk, which is purely clinical. And I'm very happy that our third speaker, Chiara Moreal from Udine, Italy, is with us. So Chiara is an enthusiastic young nurse who is currently taking her PhD studies. And as a part of her PhD studies, she was obliged to complete a 6-month period abroad, and she chose Ljubljana for her research project about prevention and management of healthcare-associated infections. So, Chiara, the podium is yours. We are looking forward to hearing it.
Good morning, everyone, and thank you for the invitation. I would like to thank in particular Professor Urbancic to be here and to speak at the Diabetes Awareness Day. My name is Chiara Moreal. I am in the second year of my PhD in Clinical and Transnational Science at the University of Udine in Italy. And my research line focuses on healthcare-associated infection and how we can organize antibiotic therapy better outside the hospital in the community. Today, I will briefly present 3 parts of my project. Mapping how outpatient parenteral antimicrobial therapy, so meaning OPAT, is used at the national level. And the second line is to prepare a clinical trial on the subcutaneous administration of some antibiotics. And the third is to building a safer and more structured antibiotic pathways between hospital and the community based on good quality data. We can think about people with diabetes that have a higher risk of infections. OPAT means giving parenteral antibiotics, usually intravenous, outside the standard hospitalization context. So it means at home, in community facilities, or in dedicated outpatient clinics. For these patients, hospital care is often necessary, However, long hospital stays have clear limits. They increase the risk of new infection in the hospital, acquired in the hospital. They are expensive for the health system, and they are hard for patients and families, especially if they live far from the hospital. So to build and improve this kind of service, we need solid data at every step. We start our research with the scoping review that looks at OPAT in Italy. So far, we have identified just 20 Italian studies on OPAT. Most of these are single center, are with observational design, and come from large hospitals. The main infections treated with OPAT include especially bone and joint infections, but also skin and soft tissue, and diabetic food infection. However, when we analyze the studies in detail, we see many differences, different indications and patients groups, different antibiotics and treatment schemes, and different level of support from community services. So why data quality is a problem? Because in everyday work, both in hospital and in community, we already collect a lot of information about diagnosis, macrobiology results, drugs and doses, hospitalizations and readmission. But often the documentation is fragmented, in particular between hospital and community. In addition, comorbidities often coded but not linked to the outcomes or to the reasons for readmission are not tracked. And finally, patient-reported outcomes are rarely collected. And this leads to three major problems. It is hard to know what really works and for whom. Second, it is very hard to compare different models of care. And third, it is hard to plan resources and to argue for changes in services. So, in my PhD program, I work with clinicians and nurses to define new strategies for patients treated with OPAT. Today, many antibiotics are given only through a vein, and this often means a central line, pumps, and a more complex care. This often means this type of problem to be solved. In our trial, we want to test whether some of these drugs can be given with subcutaneous infusions. And this could be very helpful for several reasons. Veins are often fragile and hard to assess and to maintain in out-of-hospital setting. In addition, subcutaneous injections can sometimes be easier to manage at home with the help of nurses and family members and so on and patients. However, we cannot change practice without strong data. And with this trial, we want to measure the therapeutic drug monitoring and how well the infection respond to treatment and how safe this route could be in terms of side effects and complication. So to close, I would like to come back to the key messages. So people with diabetes are at a high risk of serious infection and repeated hospital stays. So OPAT should be in the future with the subcutaneous administration of antibiotics and can help to build a safer bridge between hospital and home. The strong methodology and research development is needed to guide an evidence-based improvement for the real life of the people. So thank you very much. For any information and questions, do not hesitate to contact me. So thank you again and have a nice day. Goodbye.
For the which is mine, I will be going back to the roots. As you know, I've been passionate about diabetic foot care since the very beginning of my career. And I was a proud member of Diabetic Foot Care Assistant Project, step by step, train the foot trainer, and of course, DFoot International. And this time I shall try to present some news about the situation in the Western Balkans. Good afternoon, ladies and gentlemen. The final part of the European session will be a trip to the Balkans, the biggest European peninsula. It would take too long to describe all 12 countries in 10 minutes. It wouldn't work. So I shall briefly mention Romania, which is a very special one, far ahead of other Eastern European countries, due to the lady you can see here in the left corner, Dr. Norina Gavan, who is, I would say, guilty for two things. The establishment of Romanian Podiatry Association in 2015 and for the official recognition of podiatry as a profession in Romania, which happened at the end of 2018. I shall focus more on the Western Balkan states. Except for Albania, they used to be a part of former Yugoslavia until the year 1991. They share one feature in common, which is not something to be proud of. There is no formal podiatry education in any of these countries. The IWGDF guidelines, however, are known and translations are available. You can see Croatian and Slovenian of the 2023 edition, as well as Serbian and North Macedonian translations of the 2019 editions. Guideline preparation is a hard work, but implementation of the guidelines is even harder. We often say that a guideline is a map. Implementation is a journey. The journey is more important than the map, but a good map helps. In order to facilitate the implementation of the guidelines, Train the Foot Trainer course was organized in 2015 in Bled, Slovenia. It was well attended. There were 38 participants and 8 observers from 17 countries. The progress was discussed at 2 follow-up meetings. The first one in 2016 in Stuttgart, Germany, and the second one in May 2018 in Krakow, Poland. After that, there was a long silence until I had a phone call in November 2022 from the president-elect of DFOOT, Dr. Abbas. He said, and I agreed, that the food trainer activities for Europe should be resumed. So we organized a kickoff meeting in Hague during the Diabetic Food Symposium in May 2023. And then in February last year, the food trainer meeting was organized at Bled, Slovenia again, with 30 participants who were there in person and also 32 participants who attended the meeting online. The country reports on the second day of the meeting were inspiring. They were presented by local champions from the participating countries, whom I shall introduce a little bit more in detail later on. Soon after the meeting, I had a message from Dr. Valentina Kalinic from Bar, Montenegro, inviting the Slovenian team to come to Bar because she wanted to organize a workshop for doctors and nurses from Montenegro. As you can see here, there were many participants, and what I can say, they were all very motivated and eager to start doing the food and improve the food care service in Montenegro. The message from Croatia is strong. Anica Badanjak, a doctor from Zagreb, from Vuk Vrhovec Institute, has been the moving spirit of diabetic food care in Croatia for many years. She was also the main creator of the Croatian model of diabetic food care. But Anica retired. Of course, she has not forgotten about the food. She still takes part in the activities, but she handed over to Dr. Anela Novak, an endocrinologist from Split, a very, very enthusiastic lady who was even faster with the translation of the 2023 guideline than was Slovenia. They started the activities immediately after the Hague Symposium, and they finished in April 2024, earlier than we did. Anila decided to organize a meeting in Zadar in October 2024 in order to facilitate the implementation of the guidelines. And her motto for this meeting was, "We shall start screening." So one of the workshops at this meeting was dedicated to screening, and in particular, it was a very practical, hands-on workshop, very well attended. And on top of that, she organized a public health event on World Diabetes Day, November 14th, 2024. So she offered free food screening afternoon at the Split Polyclinic to anyone who wanted to have his feet examined. In Bosnia and Herzegovina, the foot care activities were carried out by specialists of physical medicine and rehabilitation since 2015. The two ladies here were the heads of this movement, and they were the ones who organized the Serbian translation. This document was also very useful for Serbs. And in Serbia, we have another enthusiast, the lady from Kragujevac, the doctor, Assistant Dragana Bubanja, who also decided to organize a workshop about foot care activities. It was planned for November 2024, but due to some administrative obstacles, it had to be postponed, but it was organized in March this year, and it was a great success. It was a practical workshop again. Northern Macedonia has a long history of organized diabetic foot care at Skopje Clinic. And the head person is Assistant Professor Irfan Ahmeti, who is also the Vice President of Macedonian Endocrine Society. The activities have been running since Bleed 2015, and the good news is that also there is close cooperation with Albania and with Kosovo. The last country I would like to present is Kosovo. Dr. Merita Emini Sadiku is a local champion in Pristina. She, together with her team, has established an efficient foot unit in the Clinic of Endocrinology in Pristina. This unit offers training of family doctors and nurses from other 6 regions of Kosovo and also organizes national and international professional meetings. We have developed close cooperation between Pristina unit and Ljubljana foot unit, with the doctors from Kosovo coming to Ljubljana for training. And the good news is also that the PhD students from Kosovo have enrolled for PhD studies at Ljubljana University. So, the messages from the Balkans are that nothing great was ever achieved without enthusiasm. It doesn't matter how slowly you go, as long as you do not stop. Or, as Bob Dylan said, the times, they are changing, and happy they are. Thank you. Well, we survived the presentations. I regret that the quality of the sound was not really optimal. When I checked my own presentation, everything could be heard. But now I see that some people could not be recognized as well because there was lack of sound. Anyway, all papers are open for discussion. Chiara and me will be happy to answer, and please. Well, maybe to warm the atmosphere up, I would mention once again the first 2 sessions, which addressed mostly the organizational aspect of diabetic foot care in Slovenia. Why did we decide to present our approach? Because we are sure that us resembles the Wild West, where everyone does everything, and if anything goes wrong, nobody is guilty for that. Nobody is responsible. And so we thought that it's really crucial to define the competencies of different profiles so that we know who can do what and what are the necessary qualifications for certain levels of foot care.
Can I ask a question, Vilma?
Yes, please, friend. Very
I've got
welcome.
several actually, but to the first presentation. So was your plan with the regulation of the I can't remember what you called them, the podologist.
Yeah.
We would call them pedicurists, it's the same
Yeah.
thing. Was your plan for a safety measure, as in the unregulated, or was your plan, this is a resource that we can use for better diabetes foot care in the future? Or was it simply a safety measure initially?
No, it was both.
Both.
So we wanted to be safe because many pedicurists who only finish some, I would say, short training, which is not really a training, but it's an afternoon course where they get some paper which is not certified by any institution. Then they take this paper, put it on the door, and declare themselves as medical pedicurists. And that's really unacceptable. These people have no medical background, but on the other side, on the other hand, they are very brave. When a person comes there, they cut the toenails, they remove callus, they know nothing about sterility, nothing about impaired blood supply, nothing about medications like coumarins, or, I mean, it's the philosophy, no brain, no fear. And we wanted to put the things in order and to define first what kind of training is necessary to do the very basic foot care. And then what you need to do if you want to do more sophisticated things. In fact, we wanted to pave the path to put the foot care education into the regular education system. In fact, this idea was not from yesterday. When the diabetic foot care assistant program was installed, and it was many, many years ago, my idea was to put the basic course into the secondary school for nurses and the advanced course to the Faculty of Healthcare. And we started the negotiations. Then we had some editions of the basic course, but then it stopped. And so, indeed, the point is that we want to have education at the institutions which are official, which have accreditation, and which can give a certificate which is valid. And I think we are well on the way, and that's why I was so happy that the VIST, the Faculty of Applied Sciences, said, well, we go for it. Let's start with podology studies. And it's now the third time we are doing it. And of course, much depends on the input. So on the people who start studying. If they have some medical background, then it's easier, but still, I feel we have done a step forward. What comes out later on, let's hope for the best.
Yeah, and potentially you have a massive increase in the workforce.
Yes.
Care for people who have foot problems or do the screening. It rapidly increases the number of people you have to actually do the work.
Yeah, but that part is not so bad in Slovenia because we have some on the primary care level. We have so-called model practices, and the registered nurses who work there have to complete a very, I would say, a structured training, which also contains the basics of diabetic foot care, and they learn how to do the screening. So that's good, and that means that the patients can be detected already on the primary care level. They don't have to come to specialist diabetes clinic to have their feet examined.
It's really good.
I think it's interesting that you're actually getting the manicurists and the pedicurists and all that to actually be involved, because I think they are the ones who are, people go to them. So I suppose only thing is when you just something to be mindful is when you give them trainings and all that, they get some certificates or what happens is some of them suddenly feel they are now the new leg doctors or foot doctors or foot people, basically, because we have that kind of problem over even in Malaysia also. When they do a 6-month certificate, they suddenly feel like they have got a master's in basically managing diabetic foot and all these things. So that becomes a bit of a problem. So here, basically, it's like, you train them, you say, okay, we're giving you extra knowledge on that because we want you to detect, we want you to actually send to us instead of you managing everything on your own. So actually, it's a very good program. So only thing is, we just have to make sure that, nobody misuses it. Sometimes that's the one usually we find,
yeah,
a bit of problem.
And, the good thing is that the Ministry of Health knows about these activities. And in fact, we are almost there for the official signature from the ministry of this document. And when this happens, but really it's 5 minutes to go, then we really have a tool which tells who can do what and who is responsible if he does something which he's not allowed to do.
Mm.
And that means safety.
Vilma, when we met in Slovenia, February 2024, we were discussing to have a medical legal aspect of this issue, what you are talking now, and some lawyer was supposed to come and talk and then go forward to the Ministry of Health. And can you tell me, I've lost, what happened there?
Well, that's what I'm telling. The document has a long history. It took maybe too long to get it finalized, but then it was sent to many different specialties, and all these different specialties approved the document. Now it is about to get the final approval from the ministry. And when that happens, that means that it's also a legal issue if you do something you are not qualified for.
Actually, I agree, Vilma. It's just that I think in Thailand, we have got, usually plastic surgeons who do breast augmentation or that. But interestingly, you'll be surprised, we got a whole set of GPs who are doing aesthetic medicine, board certification, the basically just the paperwork and all that. And they're also injecting basically the breast with silicons and all this stuff. And then they come up with the infection of that. And some of them have come even to Malaysia. So I end up with some of these patients on one side is completely infected and you don't know which one to actually take. So finally, we have to do a full mastect because we don't know which exact area they do it, you see. So it's always open to it. So as long as your ministry has got, what do you call this, groups like, for us, we have them as, enforcement side, then you're quite safe.
Yeah. We were very happy to get the support from them. And also the initiative that Dr. Zdenka Tičar was talking about. It's in fact the document on wound, incontinence, and stoma care. But the part of wound care was well supported by our document on foot care classification, and our document really represents an important part of this strategy. So 1/3 of the work was almost done when this strategy was getting ready.
Yep, I remember thinking from your last meeting with Abbas on that. Good.
Maybe another thing, I'm glad that Chiara is with us. Really, I loved her presentation because we all too often forget about the hospital-acquired infection or healthcare-associated infections. And we all too often forget about the problems with parenteral administration of the antibiotics. So I feel that her research work will be a significant contribution not only to healthcare outcomes, but also to the quality of life of the patients with foot infections, because being in hospital for many weeks is something that nobody wants to experience.
Yes, I am. Thank you. Hello, everyone. Thank you for the invitation. So there are a lot of high-level contributes from all the world, and it's very interesting perspectives. And yes, I'm very grateful to Professor Urbancic to develop a wider point of view on patient and about people with diabetes. Also, we have the same problems in Italy. I was really surprised about the efficient pathways that people have at Ljubljana. So in Italy, we have this problem is very different in different regions, and it's based on the individual motivation to treat people with diabetes, also in extra hospital setting. So my research is a multidisciplinary research. I think that the teamwork between and outside the hospital is the best for the quality of life of people.
Well, we can only say, Chiara, that together we are stronger. It means single country, but also in Europe as a whole. If we work together, we learn from each other, and that's the way toward improvement. Yeah.
Can I come in?
Yeah.
Chiara, I loved your presentation. Thank you so much. And I think it would be really interesting to find alternative routes of administration. We have certainly in my centre, we have a very active outpatient parenteral antibiotic service, which is very slick. But we don't have that many patients on it. And I wonder if it's because we have a lower rate of antibiotic resistance. So
that's
most
great.
of our antibiotics, you know, we would often use an IV antibiotic if we've got resistance and we can only use the carbapenems, for example. But we actually don't have a particularly high antibiotic resistance rate, maybe because we are so restricted in what we can do in our guidelines. And I wondered if you'd noticed any difference with the antibiotic resistance as you've moved to Ljubljana and a different healthcare system.
Yeah, we have a search about data from Europe, and Italy has the high rates of antimicrobial resistance. So it is maybe one problem, the One Health approach, because everyone looks at his field and not collaborate with the other part. And there are the antibiotic stewardship that need to be improved. So there are a lot of problems related to that.
Yeah, and is it a problem with you, Vilma?
It's not that big as in Italy. That's what we discussed with Chiara. We have a quite good service in our hospital. We have good data collection, and we are really not allowed to prescribe anything we want, but we have to discuss the prescription with infectious disease specialists. And in this way, we manage to reduce the problem of resistance significantly. So with us, it's the same as similar as you say, that mostly the patients who get the IV antibiotics are those with resistant strains who really cannot get anything else.
May I question? We have problem when a patient is treated with a pedicurist because they don't have a certificate. In our hospital, we work with podologists. Always they work with the physicians. Podologists no work. And another thing, in our team, we work against resistance because we have always infectologists. We always cultivate all the infections.
Yeah. Well, Daniel, thank you for your remark. The problem is not only in Slovenia, but in many countries all over the world that the licensed podiatry education is not available. And in these countries, the problem has to be solved in some other way. And as you say, in the hospital, the work is done by nurses who have had additional training, but of course they are supervised by a physician, and that is safe. But the problem is when a patient with a foot ulcer heals the ulcer, and of course, when the ulcer is healed, neuropathy is still there. Callus is still there. And if we wanted to take care of that at the outpatient diabetes clinic, of course, we would drown in the hundreds of patients coming to the clinic. So we have to send them elsewhere to have their toenails trimmed, to have their callus removed. And that's why we need certified profiles who, of course, know that they can do this and that, but they cannot manage foot ulcers. And it'll take time before the system will be really functional, but at least we have started. Yes, so maybe our president for the final remark.
I think for the very good discussion. I like the part, especially empowering what do you call this, other groups and all that, basically. And that's one way. I think we were discussing in the last 5 sessions also, basically, on how to actually expand the implementation. That's why I actually initiated even the implementation consensus and all that. So we need to think out of the box, basically, what else we can do. So I think yours is a good way to look at. And maybe what you can do is you can share with us the documents of that. The board can look at it and see whether there's any way we can actually try to expand it other places. So at least these kind of certifications and trainings can actually be more helpful. And it's good to get endorsement also. So Vilma, thank you very much. With that, I think thank you very much to all of you all from the European sector. So next we move to the number 7, I think.